Hello everybody and welcome to the Nottinghamshire Healthcare NHS Foundation Trust Board meeting. My name is Paul Devlin, I'm Trust Chair. Really pleased that you're able to be with us either watching live or watching a recording of this meeting. Just to say in particular a warm welcome to Sue Sunderland, who is at her first board meeting as a non-executive director. Sue, you're very welcome. And just to say that as we always have at board meetings a patient or staff story. Today we're going to be taking the patient story in our confidential section, just because of some confidential matters in relation to the person who is speaking with us. So it was just to assure you that we are of course making sure that we consider and reflect on some of the experiences of those who use our services. So if we move on, in terms of apologies today, I've noted apologies from Carolyn White, one of our non-executive directors. I think that other than Carolyn, we are a full house. And could I ask if there are any declarations of interest for our agenda today, please? Okay, I'm not seeing any coming through. And just to say today we haven't had any questions from the public. So if we could move straight on then to item 5, the minutes of our last meeting. And if you could just give me an indication, colleagues, if you're content that those minutes are an accurate reflection of our meeting, please. I'll just pause for a second. Okay, and if we just take a look at our action log, and again, just to see if there's any, I think we're green on all the items that are flagged on the action log. So again, I'll just pause to see if anybody wants to highlight anything from those. Yeah, and just before I move us on, John, just a reflection. I think that you just been wondering whether probably technically you need to just declare your position in relation to the Integrated Care Board, as that has now gone live. I'm sure you'll reference it a bit later on, but do you just want to do that formally for us so people are aware?
Yeah, morning everybody. John Broom, Chief Executive. We will talk a bit more later about the Integrated Care Board, the ICB now becoming a statutory body, and there is what's called a partner member, a number of partner members on that board, and there's a seat for mental health, learning disability, and autism, and the chief executive of this trust has that partner member place. So currently that is me, and I was just thinking, just for completeness, whether it will be sensible. I don't think it's conflict necessarily, but just to declare it as an interest, being a member of that board as well as this one. Thanks.
Great, thanks, John. And if we just amend the register of interest on that basis too. So if we can move to item 7, which is my report, relatively short report. I did manage to get some holiday since the last board meeting, which was good to do. A couple of things just to highlight. First off, really pleased that we've been recognised as a Veterans Aware organisation by the Veterans Covenant Health Alliance, and that's for our commitment to improving care for regulars, reservists, veterans, spouses and their families. We did have a really great flag raising event, plus some shared breakfast with colleagues, actually recognising armed forces during a week. I was pleased to attend a carer event, which I've mentioned there. Really good to be able to speak with carers directly, and also other organisations who support carers who we work in partnership with. very, very pleased that John and I were able to have a networking session with our Embrace network. That's the new name for our Black minority ethnic staff network, and it was great just to be able to have conversation, good questions and answers, great challenge. And also just to flag that I did mention at the start that Sue Sunderland had joined as non-executive director. She is now our chair of the audit committee. Our previous chair of audit, Stephen Jackson, has in the end had to finish his term just a few days early, finish his second term early, because he's taken on a role as a non-executive director at the newly formed Integrated Care Board, and that was a conflict that wasn't sustainable between the two organisations. And I think at the tail end of our meeting today, we'll just be able to have a word with Stephen. So those are the only things that I wanted to flag. I'll pause just in case there's anything anybody else wants to pull out. In which case, I'll go on then if I can. John, over to you, please, for the Chief Executive report.
Thank you, Paul. Good morning again, everybody. John Brune, Chief Executive. So take the report as read. Just a few things I wanted to highlight. The first one isn't in there much really, which again is a signifier of how rapidly things change with COVID. Again, people will be aware over the recent weeks the increase in cases nationally and the increase in numbers of people requiring hospital admission and continues apace, as does the impact therefore on the number of staff that we have off, absences, and the challenges of managing rotas across the whole of the trust remains extremely challenging. I won't fill people up with stats, but one national statistic, a 37% increase in hospital admissions for COVID over the last week, and the forecast is that the modelling is that we'll be in similar territory to where the country was in January, and it may well be another 3 or 4 weeks before this current wave plateaus out. So just again a renewed call for everybody to be up to date with all the safety measures, the infection prevention and control regulations that we're still using. We are still using masks in described situations, which we regularly communicate out to the trust. And what is in the report, Paul already covered a couple of things off. Just to say a little bit more about where we are then with all things integrated care system, the ICS, so became formal on the 1st of July at midnight. There was a meeting of the Integrated Care Board on that Friday morning to technically receive the handover from the clinical commissioning groups. The CCGs no longer exist. A lot of their previous functions transferred over, as did their staff, but there will be now a period across the country where there's a sort of bedding in of all the new structures. In the report, I've not gone into a lot of detail, but just very briefly, the ICB, Integrated Care Board, is the board that holds the ring on the provision of healthcare across the county, and that has a board with a similar makeup to what a provider trust would have, for example. So it's accountable, responsible for a whole range of different services, including mental health, learning disability, and autism. Under that sit what are called 4 places, so place-based partnerships, PB, get it right, PBPs. So increasingly you'll hear that acronym being thrown around. The other change is that Bassett Law, which is one of them, becomes part of the Nottinghamshire system, having previously belonged to South Yorkshire. And the other three are Mid Nottinghamshire, South Nottinghamshire, and the City of Nottingham. And so they're the place-based partnerships, and under those in the sort of pyramid, if you like, are primary care networks, or PCNs, and they're collections of primary care general practices that sit within the places where neighbourhoods and locality provision is coordinated. Exactly what levels of authority, accountability and finance flow down from the ICB across and into those new bodies is still being worked out and described in guidance. That will be something that will merge over the next year, 18 months. I don't think there'll be any dramatic changes anytime soon, but it's the sort of work that, from a strategy and forward plan, that we need to and are heavily involved in. The final thing to say about this is that one of the things that makes it a little bit more complex, that if you imagine that sort of pyramid, if you like, from ICB down, sitting alongside that in parallel are something called provider collaboratives. So you'll have heard in this meeting us, for example, talking about the Impact Provider Collaborative for Forensic Secure Care, is a sub-regional service. There are other emergent provider collaboratives of all different sorts of flavours. We're in another emergent one with 2 acute providers in the county. Again, exactly how they link in with host their original trusts, the new ICB and places, is all being worked through. And you can see there's a lot of work going on to ensure that the fundamental objectives of sustainable services that are more easily accessed, that are local, that keep people out of hospital wherever possible, is going to be a big job to do. On the last paragraph of that, on page 17 of the report, there's just a note within the theme of the report, is some things that don't often get talked about. We are part of another regional ICS system, the South Yorkshire one, because of the services we provide up in that part of the county. So we are a provider in the South Yorkshire Provider Alliance. So that's an alliance of mental health trusts. I think there are 5 trusts that provide mental health services in that ICS. So both Paul and myself attend that board, and we also, our services, working to make sure that we're a good partner in that collaboration. The rest of the report, like I say, I won't spend a lot of time in the detail. Happy to take questions and comments, but I've mentioned, for example, the Applied Research Collaboration, the ARC. I mentioned that because it's a really good example of some of the work that we host and contribute to that doesn't often get discussed. So the emphasis is on applied research. So this isn't sort of de novo science. This is working with the outcomes of research and applying it either into clinical settings and into industry to move things forward. And we host that in collaboration with the East Midlands universities, and there's a huge amount of work that goes on across the different themes. There's a mental health theme, there's a data theme, there's a BMI theme, BME theme, which if people are interested, to have a look. It's a great website and a whole load of literature that people can look into. I wanted to just mention the National Oversight Group. So the National Oversight Group, or NOG, is the body that oversees high secure care. So the fact that we run that through Rampton Services along with the other 2 hospitals in the country mean we're in that spotlight. We hosted this quarterly meeting and its board in June, and they took the opportunity the day previously to have a tour around some of the excellent services we've got at Rampton. And the reason that's important that the national CQC people sit on the oversight group, and many people that are connected to that regulatory oversight. They were hugely impressed with the work that they saw, both from our staff colleagues, but also from, they had the opportunity to talk to service users and patients who provided some great feedback too. And it just sort of threads into the piece at the start of the report around, we're still waiting for the CQC to complete their inspection with the inspection of Rampton Hospital. It's imminent. We don't know when it's going to be. We're also waiting for the draft reports from the inspections that were carried out through February, March and April. So we've had one which is published, which you all know about. We've got our fingers crossed waiting for quite a number from that inspection. Just finally, just wanted to mention Team Brief. Team Brief is had its second session. I think, if I put May, I think that probably should have been June, which is a new sort of refreshed engagement with staff colleagues across the organisation, which is some headlines from board, things that are on the radar, to provide essentially channels to try and reach out to an increasing and as many colleagues across the organisation as possible. And we get feedback, and it's an iterative continuing process. So again, look out for the dates. The next one is on the 14th of July. Get involved. It's a good show. There's the divisional updates there, which again, I won't go into. The final thing I just wanted to say right at the back is under staff recognition importance. Piece on page 24 was that service user has been given the Prime Minister's Points of Light Award. Some of you may remember Chelsea, who was awarded this from the Prime Minister's office, which is an amazing achievement with regard to people who are volunteering and making a huge impact with the work that they do. So thank you, Paul. I'll leave it there. Like I say, happy to take questions, comments.
Thanks very much, John. And yeah, you've highlighted quite a bit there, and also we'll note things that are in the report that you've not drawn attention to. So let's open it up for some comments and questions. Nigel, do you want to start us off, please, Nigel?
John, Nigel Smith, Non-Executive Director. Quick question on CQC, please, John. Just get the camera on, if I can. That's it. A quick question on CQC. I'm thinking about the well-led inspection that you referred to. I think it's 3 months now since they concluded on site. Is this length of time between the inspection and the report, is it normal in your experience, or is this excessive?
Yeah, hi Nigel. In my experience, it's variable, Nigel, and there are a number of reasons. I think the most likely one is that I think that they've had a very significant churn of some of their senior personnel, both in the national team but also regionally and within our local leadership, and that moving around of lead inspectors has probably contributed most significantly to this delay, and that's as much intel as we have. But it's not. Sometimes the reports come within a matter of weeks, very promptly, but other times there can be some quite significant delay. But you're right, it's frustrating because it's getting on for 3 months since they finished, and 5 months plus since they started.
Thank you.
Thanks, Nigel. Paddy, please.
Paddy Tipping, Non-Executive Director. John, you spoke at length about the ICB, which in fairness only came into place in last Friday, but it has been a long time in the planning. And you kind of commented that it might be 18 months before things really got going. But, you know, this is a major change, and it's about early intervention, it's about prevention, it's about joining up the system, it's about health inequalities. These are really big issues that we need to tackle. And elsewhere in your report, you talk about the possibility of an elected mayor for Derbyshire and Nottinghamshire. My perception is that local councils and local councillors are really interested in that, and that the ICS agenda really isn't a high priority. And I wonder what we could do to get it up, because unless we make major structural changes around things like housing, employment, training, things aren't going to change.
Hi, Paddy. Great observation, and I would agree. I think all things to do with the ICS were originally conceived as a, quite a major change of how the NHS and care system is configured and worked through. And I think it still provides us with a huge opportunity to do some real transformation around shifting or not purely being a health service when people are already poorly and requiring treatment, to get in earlier, to prevent and have swifter, faster local access. I think one of the things that people may remember, that at the height of the pandemic there was a lot of question as to whether the whole ICS program, if you like, was going to be delayed, and I think there was a relatively small delay of a number of months, but otherwise it went ahead. And I think because of the challenges of the pandemic, I think some of that infrastructural detail that you referred to hasn't all been worked through as people would have liked. I've just been saying that the next wave of the pandemic is on us, so I think that's held things back a bit. But at the same time, behind some of the headlines, there are some really important pieces of work that are going ahead despite that. So, for example, you mentioned health inequalities. There's some really scary stats, isn't there, about the discrepancies in a number of disadvantaged groups, not least people with mental health and disability. But the ICS programme board on health inequalities, which we host, I chair, has got some great engagement right across the piece. Directors of public health are involved, local authority people, councillors are on that board, and all making sure that we keep focused on some of those key objectives. And the final point, to hopefully give you some confidence that we are proceeding despite some of the governance challenges that are within the places. So again, we oversee and convene the South Nottinghamshire Place-Based Partnership. We've got some brilliant engagement with district councils in that group. We've already running some programs on tackling loneliness, on some social prescribing, but also getting into conversations about, from a mental health perspective, that access to exercise, green space, fresh air, good housing are all things that are going to make a difference. So I think some of the technicalities, if you like, about, for example, the delegation of financial budgets, accountability tiers, who's in charge, that sort of thing, may take time to really cement in. But I think some of the work that will sort of be the foundation of the things that make a difference are well in train. Thanks.
Did you want to respond to any of that, Paddy?
No, that was very helpful, John. Thank you very much. And I know work's in progress, but it's important to get some runs on the board fairly quickly. I mean, there is some scepticism, if we're honest, about what this new structure is going to deliver. And over the next 12 months, you know, being clear that these are the targets and we're going to do it, it's quite important, I think.
I agree, Paddy. I think there's within that 12 to 18 months before things set. I think there are opportunities. I think there are particular opportunities through the formal provider collaboratives that are referred to, but I think there's opportunities for more informal alliances for us, as a trust, for example, to think about how we can work more closely with primary care and primary care networks, general practice federations. General practices is under such huge strain. Again, I think there's huge opportunity for us together looking at things from a service user patient perspective that we can contribute to some significant positive transformation in that domain.
Great, thanks for that, John. And I do think that I think a part of what I hear in your gentle challenge there, Paddy, is that for us as a board, we need to keep our eyes firmly on contributing to the transformation work. And you know, we've now got a chance to move away from the that kind of focus on getting the structures set up and all of that. And actually, if we can come to the table with a real focus around the transformation, how we contribute, that will be helpful. So thanks for that. I'm not seeing any other comments coming through. Let me just see. Sorry, there's a bit of no, there we go. So I'm not seeing any other comments coming through, John. So thanks for that that report. Let's move on, if we can, then to item 9, our integrated performance report. Alison, you're going to give the usual steer through this, please. Over to you.
Thank you, Paul. Alison Wild, Executive Director of Finance and Estates for the Trust. So the report's here for our integrated performance for month 2 of the financial year 22-23 and is for the period up to the 31st of May 22. So it's here for assurance and gives performance against our regulatory and internal targets. It does highlight areas of change and where there's performance below expected levels. So I'm going to take us through in the order of the report and hand over to my executive colleagues who are the leads in the area, and starting with quality. Anne-Maria there.
So who's leading us on this, Anne-Maria? Over to you.
Yeah, no, I am here. Thank you very much. Just putting my camera on. My name is Anne-Maria Newham. I'm the Executive Director of Nursing, AHPs and Quality at the Trust. So firstly, I'm going to take you to the quality section. We've only got one thing to report today. I'm looking at page 25 or page 2 of the IPR report as you look at it. We're talking about safer staffing, and I've reported on this in the last several months around any safer staffing rates that are lower than 85% that would give us a level of concern. As reported before, Community Health Services had started to report a much better position, but we still continue to see concerns around the forensic division, which accounts for 11 out of the 13 wards with staffing pressures, which are concentrated within Rampton. The reason that we only have the safe staffing rates below 85% in the quality section is because there is nothing else that has escalated up through the divisions, and there's nothing really that is out of variation or out of line with the statistical processing charts that we run through the organisation. So that's the only one I have to report today, and the various clinical divisions will pick up their various issues that are specific to that division.
Right, thanks, Anne-Maria. I'll just pause to see if anybody wants to come in on that. I think it is the report does show clearly what actions are in place. Okay, no, I think Alison, steer us on, please.
Thank you. Alison Wild, Exec Director of Finance and Estates. I'll hand you over now to our Exec Director of People and Culture.
Good morning, I'm Jen Gwyver, I'm Executive Director of People and Culture. So just to give you an overview on the people metrics, and so then followed up by some assurance around the actions we're taking to respond to them. So firstly, in May, our absence levels reduced by a whole percent, from 7.5% to 6.5%. It's a good news story, but a note of caution that we know that we're now 5th of July, and since the end of May, absence rates have gone up, and we're at about 8% now. So just a word of caution around that figure, that things have changed since the cut of this data. In terms of other people's stats, appraisals dropped again during May. I'm really hopeful that that compliance level will increase for our June figures, because we've been doing a data accuracy exercise across the trust to make sure that all appraisals that have been done are recorded on the system as such. We've also identified some data issues that we've been able to resolve as part of that exercise, and so that should improve for next board. Mandatory training and supervision both remain strong performances. Mandatory training, I know we're high compared to our comparators in the system, and supervision and appraisal, supervision is at 78%. In terms of assurance, we're currently working on a people plan, which will underpin our making a difference strategy, and detail how we're going to achieve our ambition of being diverse, inclusive and a great place to work. And that will start doing the rounds through the sub-board committees during July, August and September. And that will underpin all the work we need to do to improve these metrics. In terms of other bits of assurance, we are now in a position where we're progressing our HR policies. So we've got a new attendance policy already launched. The conduct policy is about to be finalised. So that moves us towards a more just and restorative culture, but also should impact on people metrics. And finally, we're just about to launch our new staff wellbeing guide, which is a one-stop shop for staff who need support, whether that's financial, emotional, physical, finance. It's one document where all the support on offer is detailed.
Great, thanks very much, Jen. So let's open this up. Sue, let's start with Sue Nixon. Let's start with you, please.
Thank you, Paul. Hello, Jen. Nice to see you. My name is Sue Nixon. I'm one of the non-exec directors. Jen, thank you for the update, and clearly it was good to see that some of the absences started to go down, and I'm mindful of what you've just said about the difficulties of the new variant. My question is asking actually for a couple of comments on the charts that are indicated on page 33 of our pack, which is about the performance dashboard. One question is about staff turnover. We know that we're still very high on that, and we've raised this a little bit before. We recognise that some of this may be due to 2Ps and various things like that. But I wondered whether any further work had been done in terms of exploring those numbers and what's lying behind those. That's my one of my questions. My second question is around appraisals. I think we've learned that there was going to be a push on trying to get those appraisals done by the end of June, I think it was. I wondered whether you've had any commentary from your colleagues as to whether they've managed to achieve that. And my third question was around the freedom to speak up increase, and whether you could offer a comment on that. So sorry about those. Those three comments: turnover, issues about whether or not you know whether the appraisals have been completed alongside the aspiration that you were given by your colleagues, and freedom to speak up.
Jen, back to you.
Okay, so turnover. So there's two comments on that. Firstly, we're now really into the swing of our OD programme, creating capability, changing culture. The staff engagement culture and OD team have over 50 commissions at the moment, so that means they're working with over 50 leaders across the organisation and their teams to essentially look at how we embed our trust values into practice. The reason I mention that is that we don't just go for whoever shouts the loudest. We base that the attention on the teams with the lowest performance, and that would include turnover. So essentially, if a team was flagging as high absence, high turnover, poor appraisal compliance, they would be on the list of people to contact to offer that OD support. On a more strategic level, I think the people plan is what will answer to that turnover figure. You can't fix turnover in a month, in 6 weeks. That's probably a year project. And if we can create the right conditions, an environment as a trust to be a great place to work, people will stay. So the people plan will provide a lot of the direction around that, whether that's learning opportunities, staff wellbeing offer, the whole raft of things that you can do as a good employer. I think that will impact on turnover. So that's the sort of longer game. I'll pause and then I'll do the next two if that's okay. Okay. Yeah. Appraisals. Yeah, so these are May figures. If you remember, well, I only started in my new post start of June, and we started doing the compliance activity start of June, so we won't see those figures. We won't see the improvement in board report. However, we do check it weekly on a more informal basis, and it is going up every week in terms of compliance. So pretty confident at August board you'll see June figures, and they will be much improved. I think the key there, as we've said, it's not about ticking a box though, so it's good for us to be compliant, but appraisals need to be meaningful and add something, and that's the other strands of that work that we're working on at the moment. What does appraisals, how can an appraisal be a valuable piece of work at Notts Healthcare?
And could I ask a supplementary in relation to that, if that's okay? In terms of how they're meaningful, Jen, obviously we look at that through the annual staff survey. Are you proposing that we do any interim checks with how staff feel their appraisals are going?
We were planning to do it as part of the national staff survey. We do have the pulse survey which goes live today, but as we've discovered over the last few weeks, you can't ask every question because people are just not going to fill it in. So we've had to be really strategic about what we ask. And that's focused on those engagement questions that are tracked nationally and are tested to show engagement levels in the NHS.
Do you want to pick up the question about freedom to speak up as well, Jen? So
freedom to speak up, it doesn't sit directly in my portfolio, but happy to talk to it in general because obviously it's really linked to the work of the employee relations team. Freedom to speak up cases have gone up, as have employee relations cases. You've heard me say this before in my previous capacity. I think it is a reflection to some extent of what COVID's done to people's lives. So complexity in people's personal lives as overspilling into work. I think there will also be an element of we're now in the advantageous position that we have a deputy freedom to speak up champion, so their capacity to support our staff and speak to staff and for staff to come forward has potentially increased, and also having two different people may, with obviously different backgrounds, and may encourage different people to come forward in terms of unheard voices. So that would be my hypothesis, but if anybody, my colleagues, want to comment on that, I'm happy to step back on that.
John, I think you want to come in on that specific one. Do you want to respond to that?
Yeah, John Bruin, Chief Exec. So I agree with Jen on that, and I'd probably go a bit further actually. I think with regard to the whole speaking up agenda, large and diverse organisation, I think it's really important that we should be really clear and say we want people to speak up without fear of consequence, and we know with more to do on that agenda, I think we're in an improving position, but freedom to speak up and the apparatus that goes with it is it's a really part of the environment that we want to create for good cultures to thrive in. I'd be hopeful that we can see increasing numbers, but be able to hold that as a board and see that as a generally positive good thing. Thanks.
Thanks, John. So I've got a few more hands to bring in if I can now. So let's start with Manjit, please.
Thank you. Manjit Darby, non-exec director, and I'm the non-exec lead for Freedom to Speak Up. So I just wanted to make a comment about that. I think that the work that the champions are doing is also contributing to the rising level, and I think that that's an important step for us as an organisation. So I'm not worried about our increased rates at the moment. I think what's more important is our response to the increased raising of concern and how we manage that, and that's certainly something that I'm talking to the Freedom to Speak Up Guardian about. So but I think it is something that we need to watch. My question was really just following up from Sue's question about turnover, and as an organisation, do we really understand why people are leaving, and what are the drivers for people leaving, and what intelligence are we collecting, and what do we know?
So People Committee have had sight of this, but we use the ESR, electronic staff record, exit interview process, and it's not given us what we need in terms of intel. It's very, very basic. So we're on the list of projects that IT are working through, improvement projects, to have our own bespoke system. The vision is that we would be able to send a survey, a connection, an offer of a meeting as soon as we know someone's handed their notice in, and because then potentially we can save a leaver, and also get some more qualitative data. I'm meeting with IT this week actually just around prioritisation of the various people IT projects, because the list is Alison knows and Jan knows, sorry, that the list is endless for IT interventions, so it's work in progress.
Yeah, I mean, I think that from my perspective, understanding why people are leaving is critical to the actions that we're taking as an organisation in terms of our whole approach to staff wellbeing, kind of keeping staff engaged and wanting to work in our organisation. So I would support you in saying that that's a really critical piece of work that we really need to get on top of quite quickly. I know we've talked about it in People Committee, but understanding the reasons why people leave and then using that intelligence to help us to shape the response is really important. So thank you.
And in terms of assurance, we had the digital information board last week, and one of the actions was for me to prioritise the people, because we've got a list of people IT projects that are sitting in date order, I think. So that's one of the actions that I agreed to prioritise them.
Great. Thank you.
Thanks, Jen. And just before I bring Trevor in, Fiona, I think you just wanted to come in on the back of that,
Yes,
that specific
please.
item. Fiona.
She's froze at the.
I think you've
moment.
Possibly frozen, Fiona. Let me go to Trevor, and I'll come back to Fiona if we can get her reconnected. So Trevor, do you want to come in with your question, comment,
Sure. Please? Trevor Orman, non-exec director. Manjit's asked my first question, so I'll pass on that one about sharing. The second point, Jen, is that turnover is obviously a national issue, but are there trusts out there that are doing well? And if so, do we get access to what they may be doing that we could learn from? Because there's always somebody that knows something that we don't know, and if we can grab somebody's idea or suggestion or opportunity, then it is the information flow out there for us to be able to grab anything that somebody's doing differently or looking through a different lens that's having a positive impact.
So data flow is not particularly smooth. We get national data sets probably a quarter after they happen in bulk download. So if we want to sort of map who's got the lowest turnover in the country, we can do it, but it's a little bit out of date. However, obviously myself and my team are really well networked across the region and nationally, and I think that's a really good point, that we need to have a look at who's, and we're entering award season, aren't we? We've just had the shortlist of the HSJ, we've got the Healthcare People Management Association, so I'll definitely be keeping my eye out on the people agenda in general, of who's doing interesting new things that we might want to borrow with pride.
I think it's a really important area. It may not materialise, Jen, but it's something that sharing best practice for we're not in competition, we're all trying to fix the same problem. Thank you.
I think that's a really valid point, Trevor, and just encourage everybody around the board table to, if you do spot something or pick something up, don't assume that it's necessarily managed to get through to Jen and her team, because of it just depends on some of those networks. Fiona, I think that you're back on audio with us. Do you just want to come back in on the previous discussion we were having?
Yes, thank you, Chair. So Fiona Daniel, Non-Executive Director, having technical issues, so I'll be off camera. So it was building on to all of this great conversation, which clearly we're all very interested in, around turnover. So just to build on and just add a comment. So Manjit mentioned the importance of the, why, the why as to why people are leaving. Trevor has already mentioned around, what's happening out there much more broadly that we can benchmark on. But I think we also need to just focus back on the inside, particularly with how we connect and triangulate across freedom to speak up, all the great stuff that we're doing already in terms of, feedback, national survey. As much as the why is important, what I'm also really keen, which is why I really do want the data, is around who is leaving from where in terms of demographics. We know we have challenges, particularly around our EDI agenda for certain communities. So we really need to understand who is leaving from where, and how then we can understand some of the key actions that we need to do and take to enhance the culture to be a lot more inclusive in terms of behaviour. So I'm keen to drive this aspect forward in terms of understanding who is leaving from where, as well as the why, and how that links back into our strategic ambition.
Great. Jen, do you want to comment on that?
Yeah, I think that's true. That sort of relates to my first point around the OD programme, but there's obviously more beyond OD that we can do with teams that are flagging red across all the variables. Yeah, I need to take it away and have a bit more of a think about what else we can do.
Yeah, I think the principle of that triangulating is a really important one, isn't it? Sorry, Jen, I jumped in on you.
No, that's fine.
Okay, so just one final piece from me, if I may, which is just to reflect on one of the technical things about the way that we report in the IPR, which is really helpful for us. So on the appraisals, on page 39 of our pack, we've got our statistical process control chart, our SPC chart, and what I think is really interesting is that tells us that over the last 2 years we've not made significant impact with the interventions we tried on appraisals, and I think it means over the next few months that chart will help us see if there is an impact that is significant from the kinds of things that you were saying are starting to come through and indeed have been begun. So it was just a sort of, from a technical perspective, we might start to see them in a little while come through.
So just an update. So yes, I think some of those more strategic pieces where it will impact potentially on turnover appraisal. I've just dug out the stats from this week, and we're at 79% for appraisals, so that's a 4% increase since end of May. So it proves that some of that chasing does work.
Great, thanks very much. We've given the people work a thorough assurance test there, which is absolutely right and is, I think, consistent with some of the previous conversations we've had at board. So Alison, steer us on, please.
Thank you. Alison Wild, Exec Director of Finance and Estates. We're moving on to the month 2 performance for our operational divisions now, so I'll hand you over to our mental health exec.
Thank you. I'm Julie Atfield. I'm the Executive Director of Mental Health. I'd like to talk a bit about the current position and the onward plans around out of area. Board members are aware that we've had a spike in bed demand during March and April. And obviously our out of area use is not just about demand, but it's also about things like our infection prevention and control restrictions, our need to repatriate patients back into area, our step downs from psychiatric intensive care. It's also about our delayed transfers of care, notwithstanding that we do have some considerable fluctuations in weekly admission rates. They vary sort of between 9 and 40 per week, so it is quite difficult to manage some of the spikes in demand. And notwithstanding this, the current spike in out of area was predicted. We know our length of stay, so we know that that spike will last for probably two months. In terms of the steps to rectify this, they are in the report. But I'm pleased to say that now access to spot purchase has been reduced. It's considerably less than it was in April, but there is still pressure on psychiatric intensive care unit use, and that is still out of area. I want to outline to the board that we have taken new steps in terms of more local procurement of non-trust beds. We have taken on new provision at Kegworth. Now, geographically, that's closer actually for many of our patients than some of the other provision, but technically it's still classified as out of area. So that's been reviewed in the last few days by NHS England and will be approved to be categorised as in area. And that's waiting sign off now by our ICB. So that will improve our technical position, and it will also mean that we have a choice in the providers that we do use locally. So that's an important development for us. We've obviously got further new beds coming online this year at Sherwood Oaks, and there is an onward bed plan which was approved by the executive leadership team last week, and we will be bringing to the finance committee in August. And just a few other issues that are included in the report. You'll see the difference in IAP performance this month. That generally relates to the acuity of patients and also some of the staffing issues that we've had. I do believe that we will grapple now with IAPT performance as we're entering into a period of organisational change with that service. So that is something that we are in discussion with the ICB about going forward, how that will work. We are seeing some positive traction, however, as well in our psychological therapist service, where we've got the numbers of people waiting, which is reduced by 2/3 since last year. The access to long-term psychological therapies is often a long-standing difficulty in NHS trusts, so we're really pleased to have improved that position after so long. I do also want to bring back to the next board some positive news about our CAMHS waiting list. So this is a big area of challenge nationally, regionally and indeed locally. But we have had some positive movement in our recruitment, I'm pleased to say, which we're now able to forecast in terms of reduced people waiting. So I'm pleased to be bringing more information about that to the next board. Thank you.
Great, thanks, Julie. Couple of questions in. Start with Manjit, please.
Thank you, Manjit Darby, Non-Exec Director. I'm just interested, Julie, in the on page 43, the future inpatient demand modelling for adults and older adults is complete. It feels like as an organisation we have been using spot purchasing or subcontracting beds fairly regularly for quite a long time. There is something for me about, so as an organisation, how much of our activity do we want to be providers for, and how much of it do we want to be commissioning? Because the out of area tension that we've got kind of it waves, doesn't it, you know, depending on kind of what the demand looks like. So I know I'm rambling, but I'm just what I'm trying to understand is, and it's probably a conversation we need to have in the commissioning committee, is as an organisation, how much activity do we want to be providers for, and will we continue to be subcontractors for the longer term, or is the bed modelling going to take us to a position where we can consume our own smoke, if you know what I mean?
Yes, thank you, Manjit. Good question. So the bed modelling has really been really helpful. The good thing is it's been done across multiple agencies, so it's a bed model that is agreed by all stakeholders. It does say what we thought it would say. It's in a final draft at the moment, so it does suggest that beyond the beds that we will have in total when Sherwood Oaks is finished, that we will of course still need a female psychiatric intensive care unit, and we will need at least one further acute ward. Now that is as we had predicted, but it's usefully endorsed, and actually the model of bed review has been shared regionally for other trusts to use, so we are at the forefront of that modelling, which is a positive. Now the two things that will influence our decision making, well, the three things are the quality of external provision, the available capital, and the available workforce. Now the current Eradicating Dormitories funding does not account for the requirement for an extra acute ward and an extra PICU, so they are the limiting factors, Manjit, that we'll have to consider what is our best strategic response to.
Yeah, but with that gap, we're always going to be in a position where we're going to have to place patients out of area, aren't we?
Not necessarily out of area. There are movements in the market in Nottinghamshire, so we wouldn't necessarily have to be the only provider, and the likelihood in the bed modelling of actually using out of area is quite low, and there are different scenarios planned in terms of the decisions that the ICB might wish to take that work as a sort of stratification of the likelihood of patients going out of area, so that it rather illustrates what some of those choices look like. But I think less out of area is, you know, we would definitely get you know, a high probability of not needing them, depending on some of those decisions, of course.
Oh, great, lovely. Yeah, good work, actually, good work. Thank you.
Yeah, thanks, Julie. And just not to lose, Manjit, your kind of existential question in there about actually us making sure we make use of our commissioning committee to actually potentially do some of that thinking. I know Julie and colleagues, you know, you'll think about what's the best place to do that and how to do that, but I thought that was a really useful reflection from Manjit there. Nigel, could we go to you, please?
Thanks, Paul. Hi, Julie. Nigel Smith, Non-Executive Director. It's just a follow up on the out of area placement days that Manjit was asking about. It's looking at the chart on page 18 of the report. It's well outside the control limit, isn't it? And the ambition to set nationally a few years ago to eliminate this is clearly not working. There's something systematic that leads us to have these spikes. At the moment, it's a spike that hasn't come down, and this is really important, not just at a technical level, isn't it, on a graph, but if you are a patient who's a long way from home as an out of area placement, it's really difficult for A, them, and B, their carers to connect with them. So if they're a long way away from home for a long period, this is a significant patient experience issue, as I'm sure you know. So my question is, underneath these kind of raw statistics, I think the 480 days probably amounts to about 20 patients. I know it's not as simple as that, but is there visibility of patients who are, let's say, more than an hour away travelling distance from their home, who've been in that position for more than, say, 2 weeks? Is somebody looking at it from that perspective rather than the perspective of the raw numbers?
Yeah, so what I can provide assurance about, Nigel, is that those patients are tracked and traced, if you like. That's not probably the best term, but individually. And what we do have is what we call continuity of care principles. So we are sending or, you know, asking these patients to be cared for in environments that we have continuing care principles with. So that means that they are able to access our records, we are able to access theirs. We have links into the units to ensure that those principles of care are continued. So we know their operational policies around assessment, discharge. We follow their flow. We follow all those milestones because that's important to us about managing their care pathway. What we also do, Nigel, is take individual decisions about things like repatriation. So that's bringing people back, and about whether, you know, disrupting a care spell in one environment is a good thing or a bad thing, and whether the benefit of bringing people back and potentially destabilising that is an individual decision and it's worth doing. So the bed management team are extremely active in those realms, and particularly you know, in our correspondence with individual patients who have been out of area, we're able to see that bed management is extremely active. So we're always watching the outliers too. Anybody who's sitting in the sort of over 60 days group of patients, we're tracking those all the time. So there's a lot of individual work goes on. Fortunately, is a relatively small number of patients, so that makes it feasible.
Great, thanks. And Nigel, really good call, just to bring us back to, of course, remembering the individuals and the patients and families who are behind some of the numbers that we look at. Okay, I think Alison, you can steer us on.
Thank you, Alison Wild, Exec Director of Finance and Estates, and we're moving on to the month 2 performance from our Community Services division.
Thank you, Alison. So I'm Becky Sutton, Executive Director for Community Health Services. So there's just 3 points I want to pull out of the IPR today, take the other bits as being read. The first one is that we regularly report our number of patients waiting over 13 weeks. You can see within the report it's slowly improving, but it is below levels that we would want. But just for an assurance sake, you can see in the report the areas that we've got those weights in. So across podiatry, that I often talk about, therapeutic reablement, neurological rehab, and some speech and language therapy weights in our children and young people services. You can see on page 25 of the IPR report, or 49 of the board report, the sort of numbers. They are low numbers, and there is a very robust plan that you can see in the paper around additional capacity to bring those weights down, and we expect those to be back within line between the autumn and Christmas time as we see those weights decrease. The second area, slightly more positive, that I want to report on. So for a number of months, I've reported the length of stay at Lingsbar Hospital, which is our pathway to reablement beds, has increased. You will see we had a sharp increase of 41 days last month. That has returned to near normal limits of 31 days, little bit over our target of 28, but actually that's an improving picture. There's a couple of reasons reasons for that. One, I did report we were closed for a lot of April due to some COVID outbreaks, so we would have seen an increase because it's more difficult to place people onto care homes and places with COVID. But also we are starting to see a little trickle of the home care market, and I think we've got a more robust internal process of moving people on to their next stage in their recovery, reablement or rehabilitation journey. So that's good news. The last point to pick out is really just to highlight the excellent service that we heard about at last board around our urgent community care response. So we continue in month 2 to see a really good achievement against the standard. 99% of patients we're getting out to within 2 hours, and we're being able to re-able those patients within 99% again within 2 days. What I did want to note the board on is that we have seen an increase in activity. So our projection, we're actually 39% above our projected activity at month 2. So when I started to bring these figures, we were seeing about 150 patients a month in that service, and in month 2 we saw 340 patients. Now again, might sound low numbers, but that's 340 patients that aren't getting admitted to A&E and into hospital, and given the pressures on urgent care, that's real, real progress really. So I do expect that to grow and grow, and actually we are seeing additional funding for those kind of services starting to come, and further investment in community services, which is really good news. So that's all I wanted to highlight today, Paul, but happy to take any questions.
Great, thanks Becky. I've got one question. I'll just wait and see if colleagues want to come in. Paddy, let's bring you in before myself. Paddy.
So Becky, the urgent community response, I mean, this is a fabulous achievement, isn't it? I mean, we don't kind of talk ourselves up enough, and I think this is really positive. You talked just then about the commissioners recognising the strength of this. I mean, presumably we're pressing this hard because it ties into a system-wide approach. And my perception is that this isn't happening all over the county, but just in places at the moment. I was in Rushcliffe last week, really impressed with the staff who were involved in this, who thought they were doing a great job, and they are. But would you just chat a bit more about how we can move forward?
Yes, of course, Paddy. So thank you for that, and that's really great feedback. So yes, it's a service that was commissioned back end of last year. We were above timescale on it, so we were due to go live from April. We already had an existing service in Mid Notts, but we've managed to expand on that and spread that out to South Notts, and we were ahead of time in terms of delivering that service. You're absolutely right, Paddy, not all community services have actually been able to set this kind of service up, and we link really proactively with East Midlands Ambulance Service. So we listen in on their calls and take diverts from patients who would have had an ambulance going out to them, and we can send clinicians. It was also, we had a meeting with NHS England last week around all the sort of proactive things we can do for winter, which isn't about necessarily opening more acute beds, even if we couldn't staff them. So actually, again, I think we do need to shout a little bit more about this into the system, and actually proactively look at ways to expand this service going forward, because it's a really, really valuable and important service. And absolutely doing the prevention thing, keeping people at home, because actually if we can keep people at home, it means they don't go through an acute, and then we've got all sorts of ongoing care needs for them going forward. But thank you for that feedback, Paddy.
No, I should be thanking you, and I am.
Thanks, Paddy. And Becky, mine's just a technical thing. Could you just, you mentioned around podiatry weights, that there've been biomechanics clinics cancelled. Could you just give me a sentence that helps me understand what a biomechanics clinic is, and also whether they're ones that we run or they're run by another trust?
So I believe they are ones that we run. The exact definition, Paul, I would need to come back to you on. It'll be something very technical around yeah, I'll come back to you because I haven't got the. I'll be making it up, Paul, if I give you an answer.
Okay, apologies.
Now.
I should have flagged that ahead.
No, that's okay.
But
I'll find out and come back to you.
I'd appreciate that offline if no other way. Okay, let's move on. Alison, please steer us on.
Hi, Alison Wild, Exec Director of Finance and Estates. We're on the final operational division, so we're on month 2 performance for our forensic division. So I'll hand you over to Sue.
Thanks, Alison. Hello, Sue Alcock, Forensic Director and Medical Director in the Trust. So from a forensic point of view, it's the 2 usual sort of main topics for us. We've already talked about staffing at length, but I did just want to pick up because I think we are very actively looking at our exit questionnaires and all feedback after people have left to understand, and there is a real array of reasons why people are leaving, which is helpful for us to target different interventions. One of them that's come to light recently, just to give boards an example, is around expectations, and perhaps people coming into, there was a particular type of practice, thinking they were going to be doing a certain type of mental health practice, and actually it wasn't what they were expecting, was a theme that was coming out. So that's about how clearly we are with our adverts and our discussions and so on. So that was a sort of a newer thing that came out recently. So I just thought I'd say about that. So staffing remains one of our biggest challenges. The positive, again, for the second month running, is that we've not had any known working reported. So although it's still, you know, it's a real challenge for staff and we're having to still redeploy, and we're still using the same levels of contingency that we did through COVID in terms of redeployment and monitoring the impact of that. It's sort of at a stable point at the moment without in any way mean to minimise that. In terms of occupancy, again, I'm not going to go through what I've said before. The different areas are working to look at their occupancy, but there's essentially genuine questions in there about, you know, do we need the number of beds? Are the beds providing the correct levels of types of clinical care and so on? So one of our objectives for this year that we're working through is looking at patient needs and flow, particularly through impact, for example. So that's a sort of, I suppose, a high level summary of what that's telling us about occupancy. So I'll take any questions.
Great, thanks, Sue. I'll just pause to see if there's any questions for you. Let's see, Manjit.
Yeah, thank you. Manjit Darby, Non-Exec Director. I was just interested in the learning disabilities demand profile, Sue, whether it's just a spike that will go back to normal or whether there is a deeper issue in terms of the number of beds in our service. Just wondered if you'd comment on that.
So the information that we've got is it's been a consistent pattern now for at least a year. We've got considerable pressure in terms of finding bespoke packages. So it's more about the outflow of meeting patients' needs. There's also been impact in terms of the types of LD provision that are available in terms of low and medium secure beds across the country, which again is having another impact. So it's a mixture of all of these different reasons, and I don't think it's going to go away. So I know, for example, impact, we've had discussions nationally about that the whole pathway, because it's not in isolation.
Yeah, so I mean, in terms of the longer term solutions for this, because I mean, it means that if we haven't got flow, then patients that need the service don't get in, or we end up with patients going out of area, or we end up kind of silted up because patients are in the wrong place, don't we? Is that something that Impact is dealing with?
No, so the LD wait in particular is for the high secure service.
Right.
So it's for Rampton, and so that's why I was saying about the flow out. What we've managed to do is, so they don't go out of area at all, they'd only go into the national service. We have had discussions when it's got to a real clinical priority as to whether we could adapt a bed and the clinical provision in another sort of ward area of high security or a different high secure hospital, but we haven't got to that position.
Yeah, no, good. Okay, thank you. That's helpful. Thank you.
Yeah, it's good to tease that out a wee bit there for us, Manjit. Okay, in which case, thanks, Sue. We'll go back to Alison for the final part of the performance report, please.
Thank you, Chair. So Alison Wild, Exec Director of Finance and Estates, and here to just highlight the performance in terms of our financial performance at month 2. So in terms of spend, we're largely on target as at month 2, a 98 surplus variance against our plan. But within that, there are some large underspends on pay and some overspends on non-pay. Now that's related to our inability to recruit and also a lot of leavers since March, and the non-pay overspends are to do with the out of area beds that we've talked about earlier in this board meeting. The things to highlight to you is that nationally we're being told that following COVID there is likely to be an agency cap put back in place as it was prior to the pandemic, and our current levels of agency spend based on the previous cap means that we could be likely to overspend that cap by about 6 million. So we've certainly got some work to do in terms of our agency spend, but we've rehearsed some of that in the workforce elements about how we get a workforce plan in place to reduce the use of agency. The other thing to highlight in the financial section is our financial improvement target built into our financial plan of 20.3 million. At this point in time, there is only 9.4 million identified with a variance of 10.9 million. That's at month 2. Further work is happening as we speak, and we are taking a further report to Finance and Planning Committee on the 1st of August to update that position, which should show an improved position of more identified than 9.4. What we are working through is the phasing of all those schemes that have been identified and how we can feed that in and expedite that into this year to try and achieve that target. In terms of capital, no areas of concern at this point in time, slightly under plan for spend, but I'm anticipating that to go to recover later on in the year as the schemes are getting up and running. So no concerns there at this point. So I'll pause there for finance.
Thanks, Alison. Jen, can I just bring you in to comment on the agency forecast piece, because I think that'll head off a couple of questions.
Yeah, so just wanted to say that that's very much a piece of work that falls between both myself and Alison's portfolio. So there's a real strong people aspect to this. So making sure that our one, that we're staffed safely, but 2, that the temporary workforce that we use are treated well and are part of our team. We've got a couple of vacancies across the people and culture team, and I'm bringing in some senior support on that agenda to lead a project for 12 months on temporary staffing improvement, essentially. So that will cover bank, e-rostering, but also agency. And we'll be working, we were talking this morning about how we'll work together on that with the people and culture team leading and coordinating, but it will have a lot of finance support and work streams as well. So I just wanted to provide a bit of assurance we're not there, but we've got a plan in place.
Great, and certainly for me that graph with the trajectory on it, it would be good as soon as we can for us to see a trajectory that is not quite as moving away from the target as currently is being shown. So that would be good stuff to bring back to us. Okay. So I'm not seeing any other questions. I did just want to say, Alison, obviously, at our last board meeting, we talked quite a bit about the cost improvement programme, and I know that that's something that is being scrutinised closely through committees, as you indicated there. And again, it would be good for us to be starting to see some of those shifts in our confidence on getting nearer the target. Okay, colleagues, thanks for that. A good work through the integrated performance report. There is a great deal going on, and it's good for us to be able to keep our eyes across the breadth of what we do as an organisation. So let's take a comfort break now. Could we restart at 11 o'clock? Nigel, apologies. Did you have a question that you wanted to pick up, or was that the previous one? Thought it was a previous one. No.
I want to ask Alison if it's okay, Paul. I mean,
Sure.
My agency question has been covered, so I just got a question on FIP. Alison, looking at the table on page 30 of the report, I noticed, I should have noticed it before actually, but I've noticed for the first time that the target only exists at total organisation level and is not split down across the divisions. Is that because the divisions have not got a target?
Okay, thank you, Nigel. Good question. So we've been having lots of discussions about how we would allocate out that target, but the approach we've taken for now is where are we the most likely to achieve our financial improvement, and some of that will be about cross-cutting themes across divisions. So what we've been doing is drawing up the FIP plan, taking off those cross-divisional ones, seeing what position we get to, and then we will make a decision about how to share out the remaining target across the divisions. We have got a paper ready to go in terms of methodology, but we're hoping that that will be a much smaller part of the targets, and that they will come out naturally from the achievement of the financial improvements that we've had put forward. Does that make sense?
Okay, thanks, Alison.
Thank you.
Yep, thanks for that one, Nigel. Apologies for not spotting you and bringing you in earlier. So let's go to a comfort break. If we can restart at a couple of minutes after 11, and we'll then move on to our next item. Thanks very much. Okay, I think we're ready to restart if we can, please. So we're going to move to our next item, which is item 10, which is the annual report from the Senior Information Risk Owner, also known as the CIRO for shorthand. Alison, over to you, please.
Thank you. Alison Wild, Executive Director of Finance and Estates, and presenting this report to the board in my capacity as Senior Information Risk Owner. So this is my annual report in terms of our compliance of the work undertaken and how we've managed the risks of the information that we uphold data protection rights of service users and employees. So I will take the report as read, but there is a few things that I'd like to highlight in terms of the report. So on page 59, it talks about the Data Security and Protection Toolkit for 21-22. And there are 10 national data guardian statements for health and social care, where we have provided evidence of 109 items to the NHS digital security system. So, and I'm just pleased to report that all standards have actually been met, and we've actually received substantial and high levels of assurance as part of that, submitting that toolkit. So we've got 6 actions from that toolkit, and they're all very low risk actions that are either incomplete or in progress. So really good news in terms of the position we're in for the toolkit. The second thing that I would like to highlight is that the Information Commissioner's Office have given us high assurance in terms of our data sharing and reasonable assurance on governance and accountability. I think there are 2 areas that we've got further work to do on. One is about our compliance with data protection legislation in terms of our information governance training, and we are putting a particular highlight on that across the trust and trying to up our compliance with that legislation. The second thing to highlight, and it's on page 64 of your board pack, is about the cyber security, that further work is continuing. I think following the quick rollout of Office 365 during COVID, we were at a higher risk, but we've put lots of things in place since then, and now we're implementing a new system, and further work continues, but we are resolving issues as they are highlighted. So some really good news in terms of our compliance, a couple of areas that we need to focus on, but just the report is here for assurance and update on the work that's been undertaken. That's it. Thank you.
Great, thanks very much, Alison. I'll pause to see if there are any comments or questions. Nigel, please start us off.
Thanks, Paul. Thanks, Alison. It's not a question on the report, actually. I think it's a very good report. It's a really important area, and I'm happy with what you've described. It's in the supporting documentation. There's a couple of documents that are referred to in the reading room, which I would be quite keen to have a look at. There's the actual data protection security toolkit itself, and there's the security services serious incidents report. It might be my clumsiness, I'm afraid, Alison, but I couldn't find them in the reading room. Could you check that out for me? And
yeah, absolutely. Yeah, I'll check that out for you, Nigel, and then get them circulated around board if they're not there. But thanks for pointing that out. Thank you.
Great, thanks. So I'm not seeing any other questions or comments coming in, Alison, other than I think that's landing well with colleagues in terms of a good summary, a good update, and clearly there's a lot of work that's been going on in the background. I think those additional background documents will be helpful, but they don't impinge on us receiving the report as you presented it, I think.
Okay.
So, thanks. We go to item 11, an independent review around an employment tribunal judgment. Jen, John, I think you're doing a double act on this. Jen, do you want to start us off?
No, I'll start if you don't mind.
Okay.
John Brew, Chief Exec. Actually, I haven't got a lot to say on this other than to introduce it. This is an update and for assurance of the board. Follows on from previous meeting when we received employment tribunal judgment and an update on the actions from that. Jen will go into some of the detail around the employment law relating to it, and also to introduce some of the findings, the recommendations from the independent review that we commissioned, and to note that there's an additional ET judgment that we received in May, to just brief the board on that. Doesn't relate in terms of contents to the first one, but there's commonality in that both ETs are to do with doctors. So Sue is also going to add comment so that the board can be updated. So I'm going to hand over to Jen first. Paul, thank you.
So I think the main thing is to give assurance that progress has been made since the paper was presented in March around the findings from the tribunal, specifically that we've facilitated training for key individuals involved in the maintaining high professional standards policy. I know non-exec directors have had it, myself and Sue have had it. We've also commissioned and completed an independent review of the judgment and our actions following it, and that was the reason for the paper, really, just to advise that the independent review has been received, and the recommendations are included in the paper. The second tribunal outcome, as John said, the only connection is that this is also a medical colleague. It comes approximately a year after the first one, but just to flag that we were very pleased that it was a case relating to whistleblowing, and the judgment found that the actions of the trust were not based on the fact that the individual was a whistleblower, which obviously is really important to us because we're very committed, as referenced earlier, to our freedom to speak up agenda, and that the criticism of the trust relates to a technical employment law issue around for the reasons for dismissal. So just some assurance around that. Myself and Sue are committed to working together on this, so that we can use the expertise from the HR team in terms of employment law, but also Sue's expertise from her experience managing, leading medical colleagues to complete the actions and the recommendations from the independent review. So if you've got anything you'd like to add?
No, I think it's just to reinforce that message that it's being done jointly, and I think I welcomed the decision that was taken to do the independent review, because you will, as colleagues, be mindful that the medical group across the trust were very distressed, is probably the right word, about the outcome of this tribunal that we're talking about. So I know they met and have requested, and we just need to close the loop after we've had this now public board, how we feed some of that back. So Jen and I can agree how we do that together. As you say, it's HR and medical joined up, which is really important. So I'll stop at that point.
Great, thanks. Just in terms of opening it up, Manjit, could I just come to you first as the Senior Independent Non-Exec Director, as you technically commissioned this, just to see if there's any comment you want to bring, and then we'll see if any others want to come in. Manjit.
Yeah, no, thank you. Manjit Darby, Non-Exec Director. So in the commissioning of this review, I think that what's important to note is, firstly, the cooperation that the independent reviewer had from the organisation, and I thank everybody involved for that. I think that her feedback was that it was open, transparent, and all parties engaged in the review, which I think is important and to put on the record. She had access to all of the documentation that she requested and that we had at hand, which we thought was relevant. So I'm really pleased with the outcomes of the review, because actually this review wasn't about looking back, it was about looking forward. It is about the learning in terms of systems and processes and our governance arrangements, and making sure that actually if we find ourselves in the same situation, we wouldn't make the same mistakes. So and I think that there is the 19 recommendations that the review gives us really sets us on the path to making sure that we close off any of the gaps that we did have, particularly in relation to roles, responsibilities and the joined up working across directorates. I'm expecting that the recommendations of the review in their tracking will happen through the People Committee, and look forward to making sure that the Medical Directorate does get feedback, because when you and I met with them, Paul, they were really keen that they were engaged in the review, they saw the terms of reference, but also that they get the feedback, and and I'm really pleased that a lot of the actions that the recommendations made have already been completed. So I thought it was a good piece of work, and thank you to Sue and Jen for their support with it.
Great, thanks very much, Manjit. Just see if anybody else has got any comment to add in. I think as you said, Sue, we just need to close that circle now to make sure that the medical workforce have been able to get appropriate feedback, and I'm sure that if you want to involve Manjit and myself in that, very welcome to be part of that. It may be there's other routes to do that. I think it's a really important piece about us being able to reflect on our values as an organisation. It is really important when things come to light, even when they're relatively historic, that we are genuinely open to learning from those. And I think this is a good example of us doing that and demonstrating that. Okay, I'm not seeing any other hands coming up. John, anything you wanted to add just to finish that one off, or are you content with that? No, great. Thanks very much, everybody. Let's move on then, if we can, to item 12. Anne-Maria, it's the annual statement around Modern Slavery Act, which is here for our approval, please.
Thank you, Paul. Yes, my name's Anne-Maria Newham. I'm the Executive Director of Nursing HPs and Quality. I do bring this to you each year. So this is the Modern Slavery Act of 2015. It's our annual statement. It needs approval by the board following our chief executives and chairman's signatures. Basically, the Modern Slavery Act requires businesses with a turnover in excess of 36 million to publish an annual statement. on the steps it has taken to ensure that slavery and human trafficking is not taking place in any part of its business or its supply chain. There's 4 main areas that we look at. It's forced labour, criminal exploitation, sexual exploitation and domestic servitude. But there's no expectation on us in the Act as a trust that can guarantee there is no modern slavery in its business or supply chain, rather that reasonable steps have been taken to make them free of modern slavery. So this statement today must be approved by the Board of Directors and published on our trust website as well. And you can find it then on page 69 or page 1 of 4 attached. And I'm happy to take any questions.
Great, thanks very much, Anne-Maria. I think it's one of these things which is, it obviously comes to us annually. I think it's important that we're noting the work that goes on behind signing up a statement like this. I'm not seeing any hands going up wanting to dip into that, which is fine. But if I could then just get an indication from colleagues, are you content for us to approve this? Because we need to approve it so that then John and myself can sign it off and then publish it in the way that Anne-Maria described for us. So that's great. Thank you very much. And Anne-Maria, we're going to stick with you then for item 13, quality improvements at Arnold Lodge following the death of a patient. So if I can hand back to you.
Thank you very much. In the beginning of 2022, I brought to the board a serious incident that had occurred at Arnold Lodge, and it was around patient SD. The board then asked if I would bring back 6 months later the learning for the organisation and what had been done in order to ensure that the same doesn't happen again. So here the paper is to outline the current progress and oversight of the quality improvement plan that was put together for this young lady. So she was an inpatient on Coniston Ward at Arnold Lodge, medium secure hospital, and that was from the 30th of November 2016 until the 12th of July 2018. She was a 22-year-old and she passed away as a result of a ligature incident. The coroner did bring in an independent medical expert who instructed the coroner as to the findings, and was we did not receive a prevention of future deaths for this one, and the coroner was assured with the investigation that we gave. However, she did require the independent medical expert to give her further information that she didn't feel that was present at the time. You can see it as an older one from 2018, but I think it's been important for us to show the learning that we've taken from this. So a quality improvement plan was put together, developed by the service, which incorporates all of the actions. There is one trust-wide action which relates to the deteriorating patient and physical healthcare training, and that was relayed back to us when I don't know who that is. Yeah, so that was relayed back to us and to ensure that we did do that as a trust-wide learning. It's currently being addressed by a trust clinical priority as well, so that's been put forward as a trust clinical priority. The improvement plan indicates that all actions have been completed, and the next phase will be to review how embedded and sustained the improvements have been made. There is good evidence that care planning has been strengthened in relation to care planning, with clearer guidance for staff in respect of when to intervene in the case of self-harm and when to enter a room in the case of seclusion. And I just wanted to add, I'm looking at the top of page 75 now, but I just wanted to add that when the CQC recently came in and did their inspection, unannounced inspection I can add, at Arnold Lodge, they were very assured by what they saw in respect of care planning, risk assessments and the inclusion of carers and patients within their care planning. So there's been a high level of assurance that the CQC took as well, and overall they got good for their report. So the Directorate Leadership has established a regular forum to review their quality improvement plan, and it is led by the General Manager, who I can add as well is new since this happened. So the actions are reviewed and the evidence of completion is refreshed to ensure that learning from the incident is embedded. Since SD's death on the 14th of July 2018, there has been significant changes in the leadership and management of Arnold Lodge, and I think that we've seen some significant improvements in there. And there has been a whole service debrief that was done on the 10th of June as well. Happy to take any questions.
Great, thanks very much, Anne-Maria. And I think it's another item where it's really important that we're demonstrating our transparency around learning, particularly from such a sad incident. Manjit, please.
Manjit Darby, Non-Exec Director. I just wanted to follow up on your last point, Anne-Marie, which was when I visited the ward where this incident happened just coincidentally, and one of the things that really struck me was the impact on staff. And I just wondered, as part of our learning from this event, is you mentioned the debrief, but just how do we take care of staff when incidents like this happen? I'm just thinking about the employment tribunal from the previous item, because there was a comment in that review about kind of making sure that we take better care of people who are involved in incidents or issues, and I was very struck by how affected staff were on the ward when I visited. So just wondered if you would just comment on that.
Yeah, I will comment, but also, yeah, I was just going to say Sue probably would want to make a further comment. I suppose my comment would be is that we've got a really good debrief kind of model in place after an incident occurs. And we also have a very good way of going back to the staff and just checking in on them, see what's happened. We do it immediately, but we also do some medium and long term sort of like feedback as well. And that I've seen that happen with all of the incidents that have occurred over the last few years. So we are very cognizant of that. We also have a very good team in Alex Lyons, who looks at culture, OD, support, helps teams if they need some extra support. So that's like an external person being able to come in. But like I said, I'll leave it for Sue to just add any more into that one.
Sue.
Thanks. Sue Alcott, Medical and Forensic Director. I think I was just going to give an example, Manjit, of also how we've transferred some of the learning from this. So we had an unexpected patient death in Wathwood, which we've informed the board about previously. Completely different situation, so just taking that into account. But actually the response immediately from all levels around the ward team was completely what you would want, and the feedback from staff has been that they felt so supported just by the presence and by those sort of informal. So we can put in all the formal levels, which I think Anne-Marie has described, and we've got those. But I think having staff who have got the right values, who do those local, that you can't really mandate, if I'm honest. We do all the mandated stuff, but I just thought that was a really good example of where it's been shared and we've had a much more positive experience. This is a particularly difficult one, and I think I just wanted to be clear about, I think Anne-Maria, just about changes in management. I think the benefit of that wasn't a criticism of anybody previously, it was about fresh eyes. Actually went through the action plan. I just want to give a bit more detail. Went through the action plan in absolute detail, because after 2018 and went to say, actually, are these still right? Have we done this? Is it embedded? So that's again another piece of learning about that more independence. So I'll stop at that.
Yeah, no, really helpful. And I suppose the CQC feedback about Arnold Lodge kind of reflects that, doesn't it? Thank you. That's really helpful.
Great. Thank you. Nigel, let's bring you in, please.
Thanks, Paul. Yeah, these are really difficult cases, aren't they? I just wanted to ask for some clarity on this word embedded or embeddedness that Sue's just referred to. It says in the report on page 76 that the divisional quick review required further evidence on the level of embeddedness, and I realise this is not black and white. It's not like saying an action has been completed, tick, or not completed. There's a shades of grey, isn't there, in this? So I wonder if you just comment on that, Anne-Maria, about what you meant by further evidence required and the level of embeddedness.
Yeah, this is something that I have a lot to do with when it comes to compliance. So it's about the sustainability of changes that you have made and being able to go back in 6 months' time and find that that change is still in place. Now, that could be anything. It could be from doing sort of things like physical observations. It can be checks. It can be what you're doing with the IPC, infection prevention and control. It could be doing with what you're doing around the estate. So the embeddedness is going back and checking that the things that you have put in place, the actions that you have put in place, are still there, still being done and still understood. So that's what we mean by embeddedness. And we do, as an organisation, we have a lot of quality improvement plans for various reasons across the whole organisation. And the biggest challenge for an organisation like this is to bring about the sustainable change so that when you go back, you can still say, yeah, it's absolutely in place. It wasn't just a tick in the box in the beginning. So that's what I mean by embeddedness.
Okay, thank you.
Thanks for that.
Can I just mention something, Paul? So Julie Atfield was the Director of Nursing at the time, and she has said to us that there was a lot of work and support at the time of the incident. So I don't want people to think we've waited until now, but in 2018, there was a lot of support provided to the clinical team at Arnold Lodge at the time as well.
That's great. Thank you very much. And again, an important one. And I really like that you indicated at the start of that, Anne-Maria, that importance of, you know, when we said 6 months ago we'd like the progress to come back to the board, that gets actioned and pulled back to us, despite everything else that was going on in the trust 6 months ago, and all of those other big priorities. It's just really important we follow through on other important pieces. Thanks for that. So we're going to go now to reports from our subcommittees. Colleagues, as usual, take them as read, but let's see if there's anything to bring out. We start with the Quality and Mental Health Legislation Committee, with Carolyn not being with us today. Sue Nixon, over to you, please.
Yes, thank you, Paul. Sue Nixon, Non-Exec Director, and again, apologies for Carolyn not being here. Key point, first of all, is that no areas of concern to escalate to the board. The other thing I want to draw your attention to is that whilst the agenda was huge, there was also some very significant reports that the committee approved and are recommending to the board that they should be approved too. And those are in the reading room. You will note there's the annual quality report, which we had gone through on a couple of occasions, and there were still some minor amendments. And there was we were awaiting I think a submission on section 1, but I think Fiona has that all in hand. And that which you have in the reading room has still got the tracking changes, so it's that work in progress, as it were. And included in that, we also approved, as you can see, the infection prevention control, the complaints report and the clinical audit, all of which are annual reports. And I should draw out actually the infection prevention control annual report. It's been an absolute mammoth year, and credit to the team really in terms of everything that they've had to contend with, but so good reports there. You will also see the various other reports in the bottom left hand box that we gave positive assurance to, and really delighted that the trust-wide learning forum is really starting to come into its own, so that's important. And I should draw your attention too to the IAP service and the BAME deep dive, because that highlights that even though we may think we are hitting targets, doing something like this also helps to highlight whether there are any groups that aren't quite benefiting as much. And the Embrace group, which of course has been renamed, as you highlighted earlier, Paul, has offered any support that's necessary for this group in the future. So, as you're aware, this particular committee has the responsibility for the strategic risk around the inability to demonstrate compliance with and improvements to the standards and safety of care. And I think all the subsections of that, which are around compliance with regulations, robust learning, infection infection prevention and control standards were very important, and we feel that we've addressed those appropriately in each of the reports that gained significant assurance. However, we're not minded at this stage to alter the risk score, which still stands in the board assurance framework at 16. So that remains as it is. And the only other point I wish to raise is the fact that there are 2 or 3 pieces of work currently underway, which are highlighted in that report. The Ethics Forum, as you know, was set up during the COVID period, and it follows the Nottingham University model. So we're taking time out to explore whether we still need it now or what are the options for it in the future. As it's a non-decision making group, but there's also some important aspects to explore on that one. I think on the basis of that, that picks up the key issues, but I think it is important to note that the quality of reports that we're getting is increasingly improving. And actually, the point that I made earlier about the cross-cutting themes about organisational learning, I think that's starting to come through rather than just keeping people in silos. So it was a very healthy meeting and lots of good points raised.
Great.
And there we are.
Thanks very much, Sue. And noting nothing that was being specifically escalated there as well. Trevor, if we go to you for the highlight report from an extraordinary audit committee, please.
Thank you, Chair. Trevor Orman, Non-Exec Director. We held the extraordinary audit committee meeting on the 15th of June, and there were 2 prime reasons for this: to cover the sign-off of the annual accounts and the annual report, and also to receive the internal audit opinion and annual report. In attendance, we had 360 assurance for the internal audit, and we had Mazars for the external audit. For internal audit, we were given significant assurance, and for the external audit, we were given full approval from Mazars, subject to work being final assessments from CQC. In summary to all of the meeting, it's comprehensive reports that were provided both on internal and external, but that's the formality of what we need to do to sign off both those reports. There were no issues for escalation to the board chair. Good meeting, constructive, good reports presented, good debate, but no issues to carry forward.
Great, thank you very much, Trevor. And then the last of these, if we can go to Manjit for the highlight report from Commissioning Committee, please. Manjit.
Thank you. Manjit Darby, Non-Exec Director, Chair of the Commissioning Committee. This was our 3rd meeting. I'll take the report as read. There are no issues to escalate to the committee. I think that there's been some really good progress from the team on really our line of sight, both in terms of kind of our lead provider responsibilities, but also our line of sight as a committee on our directly commissioned services. So we now have visibility on all contracts that are worth over 250,000 in the organisation, and we're in the process of getting a really good commissioning oversight framework set up. So really good progress on this agenda. I think that the meeting yesterday really highlighted the complexity of working in the space of the system, the provider collaborative space, the lead provider arrangements and the expanding landscape here. So we had a detailed look at the commissioning roadmap from NHS England yesterday, and we've taken away some work to do on kind of further understanding our position in relation to that roadmap. But given that it's a new meeting, we are constantly thinking about its role and purpose, and I think that there is uniform agreement that it is doing a good job at the moment. So that's it. Thank you.
Thank you very much, Manjit. So, and again, nothing to raise to escalate to us as board. So we're going to move on to some items that start to pull us together. In terms of item 17, you'll remember last time we met, for the first time we had a video showcasing our services, and this is we're going to be having another one of these. Sue Elcock, I didn't know if you just wanted to give a brief intro to this, and then we can go straight to the video. I know it's not up for, we're not going to have debate and discussion, it's about showcasing, but I thought you might want to just frame it for us.
Thanks, Sue Alcock, Forensic Director, Medical Director. So really proud of our veterans services and the work that have been done over the last particularly 5 years in the Trust. Veterans work you've heard about earlier in terms of from John and Paul, but it's a big part of what goes on in offender health within forensic services, but it's often not highlighted. So we want to take that opportunity, and Jane Jones, who's introducing this, has really led with great support from Dr. Call as Clinical Director on going out and really fighting to get veteran services that are fit for the veterans for our area, and really highlight and pilot some different models. So Jane will be talking about it to you next.
Thanks very much. And Roshane behind the scenes, I think you're going to be ready to show this video, hopefully.
My name is Jane Jones, and I lead on a project specifically for veterans within the criminal justice system. This Pathfinder, as was, is called Regroup, and it is unique to Nottinghamshire Healthcare Trust. It's an integrated service, and it's a joint partnership between Nottinghamshire Healthcare, 2 veterans charities, Care After Combat and Project Nova. Operational since 2019, the aim was to inform the National Strategy for Veterans for NHS England. So the service was set up in partnership with Veterans in Custody, who helped design and shape how the service would pan out. The service has 4 main elements to it. These are the elements that were identified by the Veterans in Custody as lacking in previous services. So first of all, there's a full healthcare assessment based on somebody declaring their veteran status, not whether they have already had access to mental health services. So full healthcare assessment. This is followed where necessary by individual and group psychological support. There is training for healthcare staff, prison staff, probation staff, and any staff who are involved in the criminal justice system. In addition to that, we also provide individual mentorship, and that mentorship is a 2-year promise minimum for each of the veterans who work with our service. This is so that we don't parallel the difficulties of coming out of the armed forces in the same way as coming out of prison. Since the service started, over 400 veterans have been supported, veterans and their families, by the team. The team consists of healthcare staff and charity staff. The staff worked together in conjunction and co-facilitate with the veterans that we work with. Our biggest challenge was COVID, when the prisons closed. And so we set up another bespoke service, again in collaboration with the Veterans in Custody. This service was in the form of a remote service, and it's called Stand Easy, the name being chosen by the Veterans in Custody. The Stand Easy provision of care was supposed to be a COVID response. It has now been voted by the Veterans in Custody that this becomes a standard provision of care. Veterans do get transferred from one prison to another, and word of mouth has been beneficial. As a consequence, Care After Combat adopted the Stand Easy provision of care, and it is now being provided in over 70 prisons. This last week we sent out our 10,000th pack of the Stand Easy wellbeing packs. The packs have been independently evaluated, and the results speak for themselves. This is a bespoke service, unique to Nottinghamshire Healthcare. It has had outstanding results, and as a consequence has taken the attention of very many prisons beyond the scope of Nottinghamshire Healthcare. The service is funded until the end of March 23. Business cases have been submitted in the hope that this service will continue, if not expand. I've often been asked why veterans have this particular service, and is it necessary? Veterans have life experiences that are different from other members of society. Joining the forces brings with it a whole new way of life, a whole new family. There is a lot of loss, and in fact when people leave the armed forces, regardless of how long they have served, that they experience loss over all aspects of health and well-being. The people who come to us require help with healthcare, physical and mental health care, housing, employment. Family help is very often unseen and understated, and it's important that families are helped to work together and to live together post armed forces. So the Trust are a Gold Award winner for employment for people who've served in the armed forces. It's really important that the Trust continue that pledge to help people who've served in the forces. The complexity and the layers of complexity that present once people are involved in the criminal justice system often means that services have previously let them down, or that the services that they're facing are not adequate to meet their needs. So in order to raise awareness, we do lots of fun things as well, which we do together with the veterans in custody. So recently the charities did a bike ride around the 5 different prisons. Simultaneously, the veterans in prison were doing a bike ride in the gyms to match the 150 miles done over the 2 days by the charities. This raised awareness, with each of the governors coming out to do a welcome at each of the prisons, and presentations to the veterans are happening right as we speak.
Fantastic, and a really great service, and really good for us just to be able to hear from that service and just showcase it so clearly. So if we move to our final items, in terms of any other notified urgent business, I want to go back to something I mentioned very briefly. Sorry, I'm just looking at the just to go back to my mention around some of the changes around the board table, and I mentioned that Stephen Jackson was sitting in on the call, who had been up until the end of June a non-executive director with us. Stephen, I'm hoping that you are still on the call with us, and I just wanted to take the opportunity in our public board to thank you for your contribution over the best part of 6 years, 6 years minus 12 days on my count, to our trust as a non-executive director. And over that time, you've helped us in a number of key areas. I know that you've brought expertise around capital. You've brought expertise, of course, around finances with your audit chair function. I think one of the other things that's been really important is you very much championed and helped keep board attention on the green agenda, which has been very welcome, and I know that colleagues in our green team have really appreciated your support in that area. I'm very pleased that you are going to continue into the system and have a role within the system, and I hope that we can be seen as a good partner, and you will be able to take from all your learning about us as an organisation over the 6 years in a positive way. So if you just want to put your camera on, and I'll just give you the floor for a minute or 2 minutes just to sort of say goodbye to us as well, if you're there, Stephen. Oh, maybe Stephen's actually dipped out from our meeting there, but we will log our thanks to Stephen for his contribution, and look forward to meeting with him in his new role. So if we go to item 19, just open it up for any comments of review and reflection on how the public board meeting has gone today, please. Be good just to hear a couple of comments from people. Trevor, start us off, please.
Yeah, once again, I think the board meetings are becoming very slick and constructive. We are dealing with so much complexity of a trust in the NHS. So I think the challenge for us is continuously, how can we make sure that we keep on top of the critical issues that are the differentiators that really get us in tip-top shape. But we are moving in the right direction. So I'm very encouraged by it. Thanks, Chair.
Thanks, Trevor. Anybody else want to bring a comment in and reflect on how we've done today. I'm going to take that as a no thank you, Paul. And in which case, just to say thanks to colleagues who've been working behind the scenes, particularly Roshane, Grace, Lauren and Linda, for your support to us. Colleagues, just don't click off this link until after we've closed down the live link. I just want to explain how we're going into our part 2 business. Thank you very much for your contributions to that public meeting. Thank you.